Everyone. Hello, hello. Well, as our panel gets seated, I just wanted to give a quick introduction. My name is Nick Jackal, and I serve as the Community Relations Manager here at Cambia Grove. Welcome to the 5 Points. I see a lot of familiar faces and some new faces as well. By a quick show of hands, how many folks is this their first time at a 5 Points event? Oh, great. What a great mix. Cassie, our moderator, will dive a little deeper into the demographics here in the audience, but that's really a great overview to see who here is new. Welcome. Cambia Grove is a healthcare innovation hub aimed to connect innovators with the healthcare community. And by way of doing that, we have a 5 Points conference that really dives deep into the 5 sectors as we define them within healthcare: patient, policymaker, purchaser, provider, and payer. And so obviously here we're here to dive deep into the policy panel, and we have a lot of great content to get into. So I will just quickly hand it over to Cassie, and we'll jump right in. Welcome, everyone.
Thank you. Good evening, everyone. My name is Cassie Wallender. I am a Chief Product Officer and co-founder at a healthcare startup here in Seattle called Invio. We focus on making clinical trials safer and faster and more efficient in a compliant manner. So we're very interested in policy always. But I'm here today with our panelists, John, Julia, and Teresa, and I'll have them introduce themselves in a minute. But before we jump on into that, I wanted to learn a little bit about you, as Nick had mentioned. So let's do a quick audience poll here. A show of hands, who all here currently works in a startup or is an entrepreneur? Great. And who all here has worked in a startup or has been an entrepreneur? And then who works in the healthcare system? Fantastic. And who has worked in healthcare policy, either in government or trade associations, etc.? Okay, quite a mix. And then lastly, do we have any folks who work in support of the startup community and ecosystem? Quite a few. Great, thank you. Appreciate that. Awesome. So it looks like we have a pretty good mix of demographics here. I'm going to go through today 3 main sections with our wonderful panelists today. First, we're going to speak really briefly about the policymaker perspective and learn a little bit about each of them and, in their eyes, the view of the policymaker in healthcare innovation. And then finally, a few examples of innovations that have made impacts. Our next section will be speaking to industry trends, and each of the panelists will have about 10 minutes to present on their specific industry trends that they wanted to come talk to you about today. And then lastly, at the end, we're going to do a rapid fire and talk about high priority needs that we really need to find solutions for right now. So that's going to be a quick 5-minute at the end. Now, in between, we'll be taking questions from you guys in 2 different ways. One is the old-fashioned run around with a mic methodology, but the other option we have for you today is we're going to be using a really nifty application called Poll Everywhere, which is something new they're trying at Cambia Grove. And we have a URL here, the pollev.com/Cambia Grove 651. If you go to that on your laptop or your mobile device, you don't have to register, you don't have to install any application or anything. You can really quickly and easily type in a question, and you can also see the other questions that have been submitted as well as upvote them. So if you see somebody added a question you were going to add anyway, you can just vote for that, and it'll go right to my tablet here. So this will allow me to bring your questions to the panelists really directly. So please participate in that as much as possible. We love to get audience feedback. And that we'll be using Poll Everywhere throughout the event, so keep them coming as your curiosity peaks. And then finally, we're going to hope to wrap up just before 5 and do a little bit of networking. So please keep the questions coming until then. All right. And with that, I'm going to turn over to our esteemed panel. John?
I'm not
Esteemed. Esteemed. Please use your mic.
Oh, thank you. The joke was I'm not steamed. I'm not steamed.
Haha.
Esteemed, maybe. But so my name's John R. Graham. Thanks, Cambia Grove, for welcoming me back again. I think it's about the third or fourth time I've spoken to you, either here or down in Portland. So I'm the regional director for the United States Department of Health and Human Services. Region 10, the federal government calls it. Normal people would call it the Northwest or the Pacific Northwest. That is to say, it comprises the states of Washington, Oregon, Idaho, and Alaska. And my office is in Seattle, just down the road. So very fortunate for me, I'm able to walk here to Cambia Grove. I've been in the position for about a year, actually exactly 1 year, and I guess my third day. I came in on April Fool's Day, and now we're about 2 days after, 1 year after the next April Fool's Day. So I will be representing that department here and describing what the role of the federal policymaker is in innovation. Well, it's massive here in the United States and in most other Western democracies. Firstly, through the payment system. Medicare is 100% controlled by the federal government. And you all, when you get your paycheck, you see your payroll tax deducted to pay into the Medicare system. So through the payment system, we are influencing the policy of your access to health care, and of course through the taxation system as well. And that will become an even more pressing issue in the years to come, as you see when you look at the Medicare trustees report every year. We also, through the payment system, we finance the Medicaid program, which is actually operated by the states. But if you speak to Julia's colleagues who are on the Medicaid side, they will, I can't speak for them, but every state Medicaid director will say it's a massive, massive relationship, if we were going to put it politely, with the federal government. And every time a state wants to make a change to its Medicaid program, it has to go through various processes with the Centers for Medicare and Medicaid Services. So even at the state Medicaid level or the Children's Health Insurance Program level, federal policymakers have a huge role to play. We also, and payment does influence innovation, as I'll describe later, because what you pay for, you get what you pay for. And if you pay for innovation, you'll get innovation. If you pay for stifled innovation, you'll stifle innovation. However, more directly, of course, the United States is quite unique in the world in its funding of basic medical research through the National Institutes of Health, which has a budget of $36 or $38 billion a year, a lot of which lands in our region at UW or OHSU or other academic places around the region. And that has a demonstrated positive impact on innovation in our economy. I expect many of you, if you're startup entrepreneurs or whatever, you have a background in applying and receiving NIH grants. So those are subject to policy. What do we focus on in our National Institutes of Health? And finally, on the regulatory side, the FDA, the Food and Drug Administration, regulates drugs, medical devices, and of course on the food side it also has a regulatory role. But if you're seeking to innovate with any kind of chemical or any kind of machinery, you're going to be regulated by the FDA. And in some ways the FDA has hindered innovation, but in some ways the FDA has really helped innovation. It certainly adds an imprimatur of trust in the devices and drugs we use. And again, even globally, the FDA, for fairly obvious reasons, is the leading global regulator because this is the biggest market for drugs and medical devices. And I think the FDA is doing a great job, and I think it'll keep doing a great job. Scott Gottlieb, the commissioner, Friday is his last day, so but he set in form a lot of good reforms on the regulatory side. One of the things he's done is focused on generic drug approvals. So we've had more generic drug approvals in the last year than in any previous year, I believe, focusing on non-addictive alternative painkillers because that's a solution to the opioid crisis. And of course, a very strong campaign on e-cigarettes and vaping. Now, in terms of innovations that have made an impact, again, I'm going to focus just on the federal thing. What have we done recently that made an impact? I think I've mentioned this before. The electronic health record, which if you're a doctor or a nurse or someone who works in a hospital has been driving you crazy for a few years. We paid, as taxpayers, we paid $30+ billion to install those in hospitals and clinics and whatnot, with very mixed results, and we're trying to make sure those results are more positive. And again, I'll describe that in more detail. But that's had a huge impact on innovation in patient care. Again, probably we can debate for the next 2 days what has been positive and negative about it. But I would also say that alongside the payment system, alongside the burden of electronic health records, that has led to what I would call an innovation is the consolidation, the rolling up of practices into large groups, which concerns us, concerns Secretary Alex Azar and the rest of us in the department, that, you know, we want entrepreneurship and innovation, and we don't want, you know, we're agnostic as to what, we don't want to determine in a region what you know, the delivery of healthcare should look like. But when we see the dramatic consolidation of medical practices over the last few years, it's of concern to us, and we want to make sure that our our policies don't have negative unintended consequences on that. Thank you.
Fantastic. Thank you.
I'm Julia Terlinchamp. I'm the Washington Department of Commerce Director of Life Science and Global Health Development. And just to add to it, I'm also the governor's sector lead on life science and global health. So it all fits on, no, it doesn't actually fit on my business card. I like to think it does, but it really doesn't. Part of my job is I see myself as a liaison to the community within life sciences and global health. I just want to identify the difference when I'm probably often going to talk to life sciences, either the industry or the sector, but I do want to highlight the fact that there is a differentiation, and we traditionally talk about life sciences as a disease model and advancing novel innovations for disease prevention and diagnosis and treatment. And then when we talk about global health, we talk about how it aims to improve population health and health equity, involving broader interventions than simply biomedical treatments. So that includes the environment and infrastructure and so forth. So just for your awareness, I'm probably often going to just reference life sciences, but I want you to be aware that my job encompasses both the industry and the sector. I work with a whole range of stakeholders, everyone from other colleagues within the state family, such as Department of Health, Healthcare Authority, Department of whatever, it's a whole range. Department of Revenue, it really runs the gamut. And I believe it's my job to assess the needs and interests of the sector. So again, those stakeholders also include the business community, NGOs, research institutions, higher ed individuals as well, higher ed institutions. And so what I like to really try to focus on is that what are those needs and interests within among those stakeholders, and what is the best way that I can address them. And in my role, I focus a lot on economic development. So it's not just about what can Department of Commerce do, it's about what we can do across all of our partners and convening meetings and working with our trade organizations and so forth. And it's also understanding that we are restricted at the state level to 2-year budgets, and those 2-year budget cycles are very important to understand, because it's really challenging sometimes to talk about the long term, especially with stakeholders from the business community, when you are only able to talk about what we can get in that 2-year budget. And so that also, I should reference that legislators are elected every 2 to 4 years. So again, helping them understand the long-term importance when you're talking about economic development. And then last but not least, access to federal funding and making sure that that is reliable and accessible from a long-term standpoint. I'm just for the sake of time, I'm going to refer to the Councilwoman.
And before we move on, I just want to encourage people, we're going to go to our first Q&A session after your 5-minute intro. So please feel free to start adding questions. Thank you.
Checking. Hello. Hi, everybody. My name's Teresa Mosqueda, and I'm a Seattle City Council member. If we haven't had the chance to meet before, I'm citywide. I'm an at-large position. This is position 8. I'm one of 2 council members that's not up for election this year, thank God. There are 7 other council members that are in district. There's 9 of us total. I was elected in 2017. Thanks to any of you in the audience who are voters, appreciate it. But in my world before being a city council member, I really was a health policy wonk. If there was more wonky sauce that I could apply to our policy discussions, I would pour it on. I love health policy. This is my background. Everything that drives me and drove me to run even involves health policy. And it started from, getting my undergrad internship at CMAR Community Health Centers. Are folks familiar with CMAR? Great. Services for mostly the Spanish-speaking, lower income population, Latino population in not just Seattle, but up and down I-5. Serving then the Latino seniors who had worked their entire lives in this region and had 0 retirement security, needed additional assistance, maybe not with Medicaid or Medicare because maybe they didn't qualify, but needed additional assistance with food stamps and housing and transportation needs. And right there you saw the social determinants of health for folks who should be in their retirement age, having the very systems that they had paid into fail them. And that included the health insurance systems that they needed in those late years of their life. So I decided I was going to go on and get my master's degree with a focus in public policy and public administration. And while I did so, I worked at the Department of Health and helped to run a program on, creating healthier walks to school, safe routes to school, healthier foods in our schools, and worked really through the community health division at the Department of Health to push public policies. And there we saw the real magnitude of what these individual stories that we see on a daily basis, whether they're folks that you work with or if you're working in the medical field, the individuals that you see magnified on the public policy level, and the deep, deep need, not just desire, the need to go upstream to really invest in public policy solutions so that we can stop not just babies falling into the river, but stop entire populations from drowning early in life. So I dedicated my life to working at in health policy, from CMAR to Department of Health to then the Children's Alliance, fighting for health coverage for all kids, regardless of citizenship status, knowing that your citizenship status should not determine your health outcomes, especially for kiddos, to working at the Community Health Plan of Washington, which used to be across the street here, as their healthcare reform specialist right after the Affordable Care Act passed, and then working as the lead lobbyist and focused on health policy for the Washington State Labor Council, AFL-CIO. And in that role, in the 8 years prior to getting this job, I served on the Health Insurance Exchange Board. We fought and lobbied in the halls of Olympia to expand Medicaid. We helped to protect health coverage for all kids. And really, we got through some rough years on the glitches, as you'll all remember, with our insurance website, but really continued to say, what's next? Because that was a stepping stone. I think any of us, all of us, probably recognize and acknowledge that was the very, very least that we could do to help create additional health coverage for hardworking residents in the city, in this state, and this country who had gone without health insurance. And so for me, when we think about health insurance, and we'll talk a lot about health insurance, it's also not just that plastic medical card in your wallet that determines your health. It's truly the social determinants of health, which I think we'll talk a little bit about later. But you asked for some really key innovative policy solutions or advances that we were able to work on that have made a dramatic impact. Making sure that that plastic medical card is in the wallet of parents was something that we fought for and continue to fight for. With health coverage for all kids, Washington State was one of the first states and probably one of the first original states to still have not scaled back on our commitment to health coverage for all kids. So regardless of your citizenship, if you are a kiddo in this state and you make below 317% of the federal poverty level, you are qualified for health insurance. That is a huge win, a huge social justice win across the nation. We have now implemented Medicaid expansion, which, unfortunately, still half our states have yet to implement. Am I right on that statistic still? Maybe around that. Woefully too many. Too little states have actually implemented Medicaid expansion. And we've created the health exchange. these are some critical stepping stones, again, that have made a dramatic impact. But beyond that, there's some really critical things that we've done in Washington State that have helped set the bar for creating healthier communities. And in this day and age where we see the reoccurrence of preventable diseases, vaccine preventable diseases now rearing their ugly and lethal head, we have got to call out the fact that we have in Washington State universal immunizations. And I now have the opportunity to serve on the Public Health Seattle King County Board of Health, and one individual asked the other day, well, are people just not getting these vaccines because they're too expensive? And we have to reiterate that vaccines in this state are free. We have made a commitment to pay for that at the state level. We have coupled with some of the federal dollars that we get, but we have to maintain our commitment to these strong public policies that I've just mentioned, including basic fundamentals like making sure kiddos can have access to vaccines. These are quite literally the things that make the difference between life and death. And in many ways, Washington State and Seattle have helped to lead the way in demanding that we are not going to let our nationality, our zip code, our race, or our ethnicity, our income level determine our health outcomes. And with that said, we got a lot of work to do.
Fantastic examples. Thank you all for joining here today and being fantastic representatives of these different levels of policymaking. We have some great questions from the audience, so thank you guys for your participation. I'm going to start with the one that got another vote, so make sure you're voting. Multiple votes. Wow, this one's popular. So this is a question for everyone, and if you guys have a question for a specific policymaker, please feel free to throw that in. How should payers change their reimbursement practices to encourage innovation in healthcare? And the person added the comment, seems like ACA made some good first steps, but we have a ways to go. No, but I can repeat it. How should payers change their reimbursement practices to encourage innovation in healthcare?
You want me to jump in?
Yes.
All right.
Please do.
All right. Well, I get to be as political as I want to, right? Because that's my job. So, I mean, I'll just say I think that we have a system that we are constantly trying to amend and often amend around the edges to get at the fact that we shouldn't have a reimbursement system that rewards reimburses providers for the task or the screen or the code. We have to be continually trying to strive to treat people holistically, right? And we've made some strides, I think, as the question acknowledges, with the Affordable Care Act and some of the billing practices that we've changed. But the reality is we're still asking folks to serve people by the condition on which they have come in for that 15-minute appointment, versus recognizing that we have the resources needed, I think, to invest in a universal system that can adequately reimburse providers if we were to truly do a universal healthcare system. And I'm talking about programs like Medicare for All. I'm talking about other programs that we've tried to test out here at the state level, where those providers no longer have to think about which specific codes they're filling out to get more adequate reimbursement, because those who are serving folks on Medicaid and Medicare, even CHIP, we have woefully underpaid compared to the private market, and that is a perverse incentive to not encourage more folks to get into serving our most vulnerable. If we leveled the playing field and actually recognize that we have the resources to bump up payments across the board and treat folks more holistically, then I think we get away from the very essence of the question and we start reimbursing providers as the true professionals that they are, instead of reimbursing by code.
For those of you who aren't familiar, the governor put forward an initiative in this legislature that talks about, that's focusing on broadband. And I think a lot of people aren't aware, maybe especially in a place like Seattle, that over 10% of Washington State actually is limited to accessibility of internet or even cell phone coverage. And so when we talk about innovation, a lot of it is connected to tech, and a lot of it is connected to internet.
Sorry, can you clarify? 10% don't have access?
Yeah. So yeah, if you think about tribal communities, rural communities, underserved communities, and it's I think it's a huge number. I think it just depends on how you look at it. But we also talk a lot about the importance of telemedicine. And so in order to be able to accommodate to a more affordable and more efficient healthcare system, we obviously need to make sure that we even have that access to broadband. And in addition to that, and I've heard that this is a nationwide conversation, that a lot of health insurances are having that conversation of how do you properly bill for that kind of exchange. But that's a very important conversation, and we are very lucky that here in Washington State that we've become a leader nationwide in having those conversations, and even for example, behavioral health is clearly a big issue for us, not just here, but around the country. And we have good case studies where we have communities out on the coast, for example, where there's great shortage of providers to be able to accommodate those needs, and having those connections using telemedicine to be able to help serve those who are not being properly served right now. So I think that that's an important part when you just talk about just the foundation before we can even get to how payers should change their reimbursement system.
And I can follow on that by representing another federal department, U.S. Department of Agriculture, Rural Development, makes grants to basically lay down pipe, I guess you might call it. So they actually did it, and also loans, low-income fiber, yeah. What is it? The internet, not a bunch of tubes on the back of it. What did that senator say a few years ago? Yeah. But, Summit Pacific Medical Center out, where is it? Grays Harbor, yeah. They got a $25 million low-interest loan from USDA to set up a center. So, but coming to how then do you pay for telehealth? And again, this is the dilemma. I think the councilwoman really nailed it, Okay, well, now you get another code for telehealth, okay, and more codes to pay for. And that's kind of where we're at. On Medicare, we value telehealth, and we think that telehealth should be more available. So we've got more codes for telehealth now. But that's not that's not the end state. The end state is to pay for value, and not just per transaction, and say, oh, there's another piece of value there. Oh, let's put another code on to pay for that thing. It just makes it more and more complex. So, and again, with respect to the social determinants of health, I agree, and the secretary would agree. When you're treating a diabetic in the clinic or the asthmatic kid in a clinic, you're too late, right? It's something in the home, or it's something in the lifestyle that we need to get in front of. How does a payer figure out how to pay that? Medicare now pays for the diabetes prevention program, and Sally Sundar from YMCA Greater Seattle was speaking on the panel a few weeks ago here. Then again, when you speak to the doctor says, well, I'm not responsible for everything the patient eats. I'm not. So this is the great kind of public health challenge that I don't think we know the answer to, but I think we're asking the right questions for sure.
Mm-hmm. As a person with a background in life science user experience, one of the biggest things I hear about EHRs that's a complaint is it's not a platform for the treatment of medicine. It's a platform for billing medicine, and it focuses the experience around those codes. And that's kind of that and the conversation about broadband is a good segue into this question. Given public investment in EHRs and a general principle that health information should follow the person as opposed to the delivery system or the payer, do you believe the plumbing of health information should be a public utility? And how do we better address exchange of health information?
That's a great question. I'm not gonna. The term public utility is not something I'm gonna buy into, but we paid for these electronic health records as taxpayers, right? So that's why we, as meaning the department and the federal government, think we have the power to tell the people who installed them using our taxpayers' money that they have to be interoperable. They are the property of the patient. In the when I was in the private sector, Farzad Mostashari was the National Coordinator of Health IT in the Obama administration, and he strongly communicated that your health information is your civil right, and your data, be it in your electronic health record or in your manila file folder, is your property. And we continue that commitment. We also have finally proposed a rule on information blocking And in Medicare, there's the Blue Button Initiative, Blue Button 2.0. Another term you might hear in the Medicare world is My Health E-Data. Get it? My Health E-Data. Trying to encourage people to understand that their health data is their property. They can share it with whomever they decide, not the payer, not the hospital, not the doctor.
Okay. Nods all around. That's great. Well, let's move on to our next section, and then we'll hold some of the questions for later, and talk a little bit about industry trends. So just as a quick reminder, we're going to give each of the panelists about 10 minutes to discuss or present on a specific trend that they've proposed to bring to you guys today, although they're welcome to have some discussion amongst them all on that trend. And then at the end of each of the 10-minute sections, we'll go to 4 minutes of questions via the app or via the web application. So feel free to throw your questions in there as they surface. And then at the end of all three, we'll also do a live Q&A session with microphones and running around. So we're going to kick things off with John.
Thank you very much. I noticed Julia's still writing her talking points, so she's obviously I'm either saying something awful or wonderful that she's going to. Well, the topic I'm going to discuss is the shift to value or value-based reform, which you've all heard all kinds of people talk about it, for a number of years now. But it's very important. I think it has had an impact, and it's going to continue to have an impact. Within the department, the U.S. Department of Health and Human Services, this is one of our 4 priorities, and the other ones being prescription drug prices. Excuse me. Well, let's focus on this one. But actually, I should say all 4, just because they do intersect. So prescription drug prices, affordable health insurance, and the opioid epidemic. And they do intersect with what we call the shift to value. What we're focusing on is 4 areas that we think will shift us to value. One is maximizing the promise of health information technology, including interoperability of health records. Second is boosting transparency around price and quality. Third is pioneering new models in Medicare and Medicaid. And finally, removing government burdens and barriers, especially those which impede care coordination. And the primary office within our department which does this is the Centers for Medicare and Medicaid Innovation within the Centers for Medicare and Medicaid Services. It's currently led by a fellow called Adam Baylor, who joined about a year ago. Used to be led by a fellow called Dr. Patrick Conway, who stayed with the new administration for about a year, so I got to know him a little bit. And he ended up at Blue Cross Blue Shield of North Carolina, which is now entered a strategic partnership with Cambia Health Solutions, the parent of Cambia Grove, and the Blue plans around this neighborhood. So hopefully we can get Dr. Conway to come out and tell us how, as a leader in a private payer environment, he's continuing his efforts in the shift to value. So he was a guy, like I say, I got to know a little bit when I was back there. Now the authority, well, let's just call it the Innovation Center. That's what we call it in the department. It was established by the Affordable Care Act. So there's one part of the Affordable Care Act we love, and it's the Innovation Center. And it is empowered to do demonstrations for Medicare, Medicaid, and the Children's Health Insurance Program. Now, of course, when it comes to Medicare, because it's all in the federal government, we don't deal with the states. We can do what we want without talking to the states. So some of the most exciting things that we're announcing quickly are in the Medicare program, but there are also things in Medicaid and CHIP. Now, again, the Secretary has broad authority through rulemaking to roll out new demonstrations, new models. The constraints are that it must either reduce spending without reducing quality of care or improve the quality of care without increasing spending. So there's the 2 kind of constraints. And these determinations are made by the CMS chief actuary. So there's still a regulatory thing there that the actuary has to say, yes, it will perform on one of these 2 vectors. And currently, the Innovation Center is focused on the following priorities. One is testing new payment and service delivery models, including quality payment program, advanced alternative payment models, evaluating the results and advancing best practices, and engaging a broad range of stakeholders to develop additional models for testing. Now, what you're probably most familiar with is the Accountable Care Organization, the ACO, which was the first kind of thing that rolled out along with the bundled payments. But the ACOs really kind of took off, and they took off in such a degree that it became a generic term. You know, if you get an email from Deloitte or whatever, they use ACO in a generic way. So we believe the experience of ACOs has been mixed. I think the research would indicate that. Some folks will say the physician-led ACOs did better than the hospital-led ACOs, or vice versa, or whatever. So there's a mixed body of literature on the outcome of the ACOs. But when an ACO succeeds in both delivering high-quality care and spending healthcare dollars more wisely, the ACO will share in the savings it achieves for the Medicare program. And we are learning from the ACOs that were set up in the previous administration and that we continue to roll out. There are some specific things, again, I think with respect to the Councilwoman's bringing up the issue of social determinants of health and public health, and how do we integrate these public health concerns with the payment system. An example, again, as we learned at our last 5 Points event here at Cambia Grove, Medicare is now paying for the first ever preventive services program in diabetes. So paying non-clinical providers like the YMCA to prevent diabetes, and that will reduce costs down the road. And that model was actually developed not just by the Centers for Medicare and Medicaid Services, but Centers for Disease Control and Prevention and NIH funding actually contributed to doing the research that built up the model. Some of the new things we've rolled out recently is a model on maternal opioid misuse, MOM, okay? And that model is very exciting because it intersects with our opioid priority, right? The mother who's suffering from opioid abuse disorder will give birth to a baby who suffers neonatal abstinence syndrome. So we have a new a demonstration that's just rolled out called Maternal Opioid Misuse. And if it interests you, we have a webinar tomorrow, April 4th at 1:45 p.m. So if you want to sign up for that webinar, just Google it and you'll find it. Another thing we rolled out, again, it's not, we solve the problems that we see, and if we think we don't need to boil the ocean to solve them, we solve them by not boiling the ocean. So another example would be what we call the ET3, Emergency Triage, Treat, and Transport. It's probably called ET cubed, but I'm not good enough at math to say that, so I'll just call it ET3. So this is a voluntary 5-year payment model that will provide greater flexibility to ambulance care teams to address emergency health care needs for Medicare bennies following the 9/11 call. Until now, the ambulance had to deliver to a hospital emergency department, or in some cases a skilled nursing facility or something like that, but that may not always be the right place. That's the most expensive place to go. So in circumstances where you can deliver the patient to a less expensive place of care, the ambulance can still submit a claim. So higher ambulance costs, but lower costs overall. I'd also like to say that we've got, we've just announced, the president signed a executive order on American leadership in artificial intelligence. So CMS has announced an artificial intelligence challenge for predictive health. Again, the information for that was just announced a few days ago, maybe a week or two ago. So those of you who are involved in the AI sector, please research that, because we think artificial intelligence, better use of, better for precision medicine and predictive medicine. And again, we really would love to figure out better ways to pay for social determinants of health. The examples I said, the diabetes prevention program is a step in the right direction, but there's a whole swath of stuff where we'd like to figure out how to better pay for that and integrate, as the councilwoman said, the public health needs with the payers' priorities. How are we doing? 1 minute warning. And then I would just like to point out, take my last minute on kidney. End-stage renal disease. So this is a big problem. The way we've paid for kidney care is basically unchanged for about over half a century. In other countries, in Guatemala, 56% of ESRD patients get in-home dialysis. I mean, we lag Guatemala in in-home dialysis. We're still taking people out to the dialysis center. And so we have announced an innovation model in kidney treatment. We've also announced through the Chief Technology Office something called the Kidney Accelerator, actually innovate the technology of developing artificial kidneys to help relieve the shortage of, I don't know what we call them, natural kidneys for transplantation. And so we're all hands on deck in the NIH and other parts of the department on developing, innovating kidney treatment and developing new therapies for kidney disease and new ways to pay for it. That's it, 0 minute. Thank you so much.
Thank you, John. So quick couple questions for you. How can entrepreneurs learn more about new policy initiatives that may involve government procurement of innovative services?
Well, thank you for the question. I'm glad the word procurement was in the question, because I'm going to discourage using that word. We're not, the VA procures stuff. DOD has a big health system that procures stuff. We do have a closed health system within HHS called the Indian Health Service, which runs its own clinics and hospitals in Indian country. But I mean, if you're interested in, if you have a new innovation that you think would be useful in the Medicare or Medicaid program, we don't literally procure it. It's driven by doctors, it's driven by providers. So we have to, if there's an innovation, we approve it. I know the councilwoman and I are on the same boat here. You got to get a code, and then you got to get coverage. But we don't actually procure it. It's then driven by the providers who will prescribe it or whatever. So the best way would be just, this sounds so trite, but just go to the Centers for Medicare and Medicaid Innovation, sign up for their emails, go to the Chief Technology Officer, sign up for their emails. When there's a webinar, go participate in the webinar and figure out what they're looking for, and if they're saying, look, maternal opioid misuse model, kidney innovation, and that hits you, then that's respond to it. And the other thing, again, so much of what we're doing is going to have a lot of upstream, right? So if we're paying for value, and I think a lot of entrepreneurs have figured this out, if let's say we're really turning the screws on readmissions to hospital, right? So we think high quality care means an avoidable readmission to hospital should be avoided, and there's I don't know what the right word is. I don't want to say punishment. I have to use the regulated language in case the lawyers are listening or being required. But you won't get paid what you think you're going to get paid if the patient is readmitted to the hospital for an attributable problem within a certain number of days, right? So that means upstream. So the hospitals have to figure out where do I discharge the patient to? Is it the nursing home? Is it home? Is it so the entrepreneur can say, look, I can make the case that we can reduce your avoidable readmissions by discharging to our site of care. So that's got nothing to do with the government directly. That's you going to the hospital or the health system and saying, I can help you solve this problem that Medicare is punishing you for.
Thank you. Now we're going to spend 10 minutes with Julia discussing workforce development.
Sounds fun, right? I found that this is an important topic to talk about, mostly because of the long-term impact. I think that it's very obvious that Washington State is known for its innovation and incredible workforce at the present. However, we don't really talk about the long-term impact of all of our top high-demand sectors that have the same needs that we do within this field. And so when we really talk about a shortage, we're actually talking about a shortage particularly in the STEM field across a number of different sectors. So what are we well known for? IT, aerospace, obviously life sciences as well. And so we have to all share from the same pot of engineers and tech folks. Just when it comes to life sciences, we need just a little extra something. And I like to give this example that I recently heard from a company that was telling me that it's extremely difficult to compete with Google and Facebook and Microsoft and even Amazon, because they have, especially people coming right out of college, and they come and work into a lab, as with the tech or engineering background, and they go, oh my God, it's like so strict to work in here. Like I can't use my phone all the time. I can't like eat my snacks. I want to eat my Fritos while I'm doing my work. And they're going, well, there's this thing called the FDA and some regulations, and so it's really hard where they have to compete with not only the price point of hiring them, but they also have to compete with being able to yeah, that was an example that was used. Like who doesn't love bringing their corgi to work? But supposedly, I guess the FDA is not into. I don't know, John. Maybe work on that one. So it's my. Please pass that on.
Genetically modify a corgi that doesn't shed.
So that's an important point to understand. And if you even look again more broadly, manufacturing is a big part of the life science community here, especially with med tech. And a report came out a few years ago that identified across the U.S. that they expect that there'll be a skill gap. Due to a skill gap, there'll be about 60% of positions unlikely to be filled, because there's just the skills, they lack the skills and the available people to be interested in going into those professions. And so going back to the availability of skilled talent, both now and in the future, we have a long-term challenge within the life sciences. And a report came out in the last couple years, actually a few reports have come out, interviewing industry executives about what are the main challenges that this industry faces. And you probably heard about the affordability and accessibility of lab space. I'm sure you've heard about availability of investment capital. And I don't know how much you've heard, but it's a big issue. It's that workforce that I've just talked about. And it's obviously also compounded by the number of retirements that we're expecting to see and are starting to see. So it's not just high-skilled jobs as well. So, we have a number of companies making location decisions regarding expanding and even just retaining them, because for their headquarters, for research and development, for manufacturing, and they're calculating a number of factors for that growth. And so when it comes down to it, they're taking into consideration that long-term growth. So I have a company that I've been working with that is planning to hire 150 people this year. They're not getting them from this area. And so I have some companies are telling me 25 to 30% of their employees come from out of state. And I also want to clarify that it's not just high-skilled individuals. We're looking for people who are also middle-skilled. So those middle-skilled folks, that includes people with just a few years of training and work and education. It doesn't mean that you have to have a 4-year degree, and it definitely doesn't mean that you have to have a PhD. So, we have there's a lot of data out there that talks about this availability, this gap, and so I will skip over that due to my new number I got. I just want to talk about the education system and how important it is, and that's something that was recently, there's a new report that came out in the fall by Facility Logics, and it included 6 community colleges in UW-Bothell, and so it's really specific to the Seattle-Bothell area. And we talk a lot, what we hear a lot about is the disconnect between industry and schools, and you can see this in the curriculum that's offered. And so you have a lot of people coming out with fantastic degrees, but it doesn't mean that they're prepared to be able to join into the lab. So then you're going to need to add extra training, and then there's you have to add retainment, and then you have to add, competing with other kind of companies. And so in addition to that, you also hear quite a bit about the lack of awareness as a real concern within the education system. So just understanding that there's more to this field than just becoming a doctor or nurse. There's actually an incredible array of jobs. And again, it doesn't mean that you have to have a PhD in microbiology. You could just, you could learn to become a skilled technician within a lab and be able to help change lives and improve people's health and well-being, all within, just, with only a few years of education. So I guess I'm just going to conclude about how we really need to address the critical gaps for jobs and for specific jobs and skill sets. And so that is being looked at right now. And so I would just really want to bring up an initiative called Career Connect Washington that's in the legislature right now and is being pushed hard. And we are really lucky to have fantastic partners. And one of them, Ingrid's here from Life Science Washington Institute. Life Science Washington has partnered up with AGC Biologics with support from Career Connect Washington. And this highlights public-private partnership. It's a very sexy word right now in the legislature. And so if you ever really want to know how to really get something done, it's P3, public-private partnerships, because that's going to be the reality of we need to be able to have all voices at the table, making sure that everyone's interests are being heard. And in this case, AGC Biologics has this great paid internship program that they've just launched in February, where it pays high school students to learn what they do there, get school credit, get paid, and then eventually even to maybe stay on. And then they're also looking to launch an apprenticeship program, and I can continue with that if later on. Yes. Okay. Yay.
Oh, fantastic. Yeah, we're going to go to questions. Thank you. Awesome. That's fantastic. I myself started out my career in a work-study job at Seattle Biomedical back in the day. And I won't say how long ago, but their name's changed several times since. So those programs are fantastic. So I'm going to go to a couple questions that specifically were speaking to the career question. First of all, we have one that says, how is the state considering innovations in allied health to address workforce changes?
Well, we have something called a Center of Excellence. It's actually a Center of Excellence for Allied Health. And his name's Dan Ferguson, and his job is to work with all the community colleges, community technical colleges across the state as a liaison with industry and those colleges. And so that actually in the Career Connect Washington package, the governor's package, there is additional support to community and technical colleges to be able to add to that. So that is one element. I can't speak to this because I don't focus on traditional healthcare, if you will, most of the time. But there's a great nursing shortage that the HCA in particular is really focusing on, and we're doing some really innovative things here in Washington State. And I don't know if that speaks to the question per se, but there's some people are having to be very creative in how to address it. And so we are working on trying to provide greater resources to be able to help support those kind of programs.
Fantastic. Here's another great question. Primary care costs less than specialty care as long as surgeons and proceduralists get 5 to 10 times more payment per time than primary care. We won't have enough primary care. Has anyone considered removing work relative value units from specialists and increasing them for primary care?
That was really long. Yes. State the last part.
Has anyone considered removing WRVUs, work relative value units, from specialists and increasing them for primary care?
I work for Department of Commerce, so that is not within my awareness. But whoever asked that question, I am happy to help get a more direct and educated answer from someone within an agency that can best respond to that. I'm sorry, I can't speak to that.
That's quite all right. Some of these questions are. Go for it.
I mean, there is a process for updating the relative value units, and the RUC you see, and it's a process that the physicians basically are the determining people, and they meet, and they it's a long-standing issue, and I don't want to editorialize on it, but I mean there is a process within Medicare that determines these relative value units, and any idea for reform, let us know.
Yes, you had it on. That was great. Thank you. All right. Let's see. We're last but not least, we'll move right along to Teresa to speak on how workforce conditions impact health outcomes.
Thank you so much. And actually, some of the things that you touched on are things that I'd be interested in discussing with you all and hearing your feedback on as well. So my committee that I get to chair at the Seattle City Council is called Housing, Health, Energy, and Workers' Rights, which I chose specifically because the acronym is HER. It's HER committee. And when I was asked, what committee issues do you want? I said health and housing and labor, right? Because of the social determinants of health. And for me, what I've been trying to do is to figure out what leverage, what role the city council has in improving people's health within the city of Seattle, right? There's 750,000 individuals now in our city. We've seen a population growth of about 20% since the beginning of this decade. 120,000 people have come to the city of Seattle to take some of these jobs, to fill some of these roles, and yet we have not built the housing that we need, and we have not responded with the infrastructure that we need. And in many ways, I actually think a lot of folks are coming here, and many of our companies have been successful because we actually done a good job at investing in the workforce needs, in the labor protections. Seattle's been the incubator of places that we think about in terms of labor standards around minimum wage. We were one of the first in the nation to fight for $15 an hour, the first to lead on sick leave and wage theft protections. We had family leave enacted, and then the state followed. We have been a true, I think, groundbreaker in terms of labor standards protections here in Seattle. But the reality is many of those labor protections are not translating into better health outcomes yet for some of our most vulnerable workers. Last week, I was at a conversation about hotel workers and hotel industries, and there was this woman who was giving this story about how many hotel rooms she cleans, and I think that there's some staggering number, about 20-some hotels are opening in Seattle in just the next 3 to 5 years. We are a place that people want to visit. We are a place that people want to come and see their family or visit our beautiful neighborhood, and we want to be welcoming to those folks, and we need these hotels. And along with hotels comes incredibly hard work. They are cleaning these rooms. They are there's a quota that they have to meet in terms of number of beds that they have to clean. There are heavy comforters that they have to lift up and laundry that they have to move, and it is quite literally backbreaking work. And she talked not just about her incredible workload, but then she talked about something that resonates with me because I also had a miscarriage last year. She had 2 miscarriages in the period of 2 years and had asked for pregnancy accommodations for both times, and both of those light duty requests were denied. We have a staggering number of industries, not just here in Seattle, but across this nation, where we're seeing increased numbers of health complications due to increased amounts of stress in the workplace. And I know that miscarriages are very common. In fact, we know that the data is very underrepresented because a lot of folks might not even know that they're pregnant in those first few weeks. But when you see 12-week, 10-week, 16-week, 18-week, 20-week miscarriages, and the number of individuals who've reported these incidents of their health, their physical health being impacted by the labor standards that they experience every day, there is a trend directly connected between labor protections that we need and health outcomes. 2 weeks ago, I was at a conversation with the United Farm Workers, calling on the folks at Dairy Gold to help raise the standards for labor protections for the very milk that many of us drink every single day that goes to Starbucks. Starbucks is the biggest recipient of Dairy Gold farmers' milk that is produced by farm workers in this state. And yet many of the women dairy workers that I talked to had experienced not just miscarriages, but extreme pain and increasingly dangerous work conditions. 2 years ago, we heard about not just the first, but now the second individual who's drowned in a manure pit. We're hearing about changes in, that's the right reaction, yes, drowned in a manure pit from cows at the dairy farm, because a lot of times that manure pit almost appears like it's solid and grass will grow over it, and there's no protections to keep individuals from falling in, and it is 24/7 work. They are milking these cows 24/7, so at night, without proper lighting, without proper protections, people are dying. I bring this up because we think of all these labor protections that we've been so good at protecting, and we think of ourselves as the progressive corner of the country and this blue state, and maybe you're not all thinking about blue and red all the time, but we think about ourselves being ahead of the curve a lot. Right here in Seattle is where I talk to that hotel worker. Right here in Seattle is where I talk to that dairy worker. And then we have right here in Seattle some of our really great companies who've been successful in our own backyard. Oh my gosh, tell me it's not 2 minutes. Okay. Where we have seen increased numbers of people who are working very long shifts, and that includes the staggering numbers of not just miscarriages, but suicides at warehouses, right? I see some folks nodding. There was a big headline statistics about this. The number of suicides in warehouse workers, in warehouse work, especially at places like Amazon. We have examples of taxi drivers who are committing suicide because of the higher numbers of Lyft and Uber drivers on the road that are outpacing their ability to get medallions for taxis. We hear about healthcare workers who are mostly women and people of color working without uninterrupted breaks in 12-hour shifts. And we talk a lot about the lack of childcare in this city. We have the most expensive childcare for infant care in this city than we do in the entire nation. And who's working in those jobs? Mostly women and people of color. So I bring this up as a way, and I swear to God, I have 4 note pages here, and I only got through 1. But I bring this up as sort of the tie-in to say, absolutely, all of the issues that we talk about, and I know you talk about, and I will continue to be at a rally this weekend talking about in terms of expanding access to that plastic medical insurance card and making sure that healthcare insurance and healthcare access is truly a right. But we have, I think, among you all as both entrepreneurs and industry experts and folks on the front line thinking of these innovative solutions, we have a healthcare crisis. We have a health outcome crisis in our own backyard because we have not figured out yet how to ensure that every workplace is truly safe and that the pregnancy accommodation 4-paragraph piece of legislation that was passed 40 years ago is actually enforced, and that people who ask for things like light duty or speak up when they need better protections in the workplace don't get fired or retaliated against. These are the very protections that I think we never, well, I shouldn't say never, we often don't equate to a health care issue. And so folks often ask, well, how the heck did you go from working at Community Health Plan of Washington and CMAR and all these, health-focused jobs to now working at the Labor Council, AFL-CIO, and then being City Council? It is because all of these issues that we touch on, access to affordable housing and labor standards, and you mentioned environmental toxins, in the home or maybe smoking or something like that. But the environmental toxins that we're exposed to as frontline communities and fence line communities, these are the issues that I think we as industry can help raise up in terms of protections so that people are making the connection between the actual labor protections being healthcare protections. And I'll end with this because I know my time's up. How many of you are familiar with Dr. Stephen Beshrushka at the University of Washington? Oh my God, no hands? Okay, he's incredible. He's a professor of public health at the University of Washington, and he's an author to a book called Sickness and Wealth. He talks a lot about the health Olympics. In fact, he should say the mortality Olympics, because if this was a competition with any other industrialized country in the world, we would be losing these Olympics. We have staggering statistics that we can get into later about infant mortality, maternal mortality, life expectancy, where we've seen other nations do much better when it comes to issues of child death rates, and we all are shocked every time there's a mass shooting. Every time there is a mass shooting, those deaths do not amount to 1 day's typical child mortality rate here in the United States. Mm-hmm. So the question is not, do we have enough money, can we afford to do more? We do have to fight for that plastic medical insurance card because we can't afford not to. And we also have to think about these social determinants of health right in our own, friends, in our workplace, in our neighbor's workplace, that is actually harming our health and specifically harming women and people of color health.
I have a lot of questions specifically for you. So first of all, we've got one that says, what?
I don't know how you've had time to do this. Okay,
they're
this
amazing.
is impressive.
I actually have to give huge props to the audience because all these questions are so good and I can't get to them all. It makes me sad. So hopefully we can do something with the extra questions at the end, but perhaps we can send them to our panelists. Someone says, for Teresa, what rally? When? Where? I want to come.
Excellent. This Saturday, there is a Medicare for All rally that Congresswoman Jayapal will be hosting. It is at 11 a.m., and I left my phone back there, so I will get you the exact location. But she and a number of her colleagues, I think it's 100 and almost 50 people in Congress now have signed on to Medicare for All bill. And so this is really calling attention to the fact that this isn't a pie in the sky idea. This is truly something that quite literally 44 other nations, a lot of capitalist nations, have already implemented and have not seen it, crumbling. The sky has not fallen in their country. So that's what the rally is this weekend.
And then another question specifically for you. What's your response to the documentary Seattle is Dying regarding public health problems around drug addiction and encampments?
Okay, great. So this seems like a very data-oriented group. I would encourage folks to take a look at the fact check that has happened with Crosscut, with The Stranger, and there's one more publication that actually ran corrections on the Seattle is Dying documentary. In fact, some of the very people that were featured in that documentary have talked about the successes that they've had with getting into housing. The concern that I would say is Seattle dying? Well, if you looked at the data from last night, we have staggering numbers of homicides right now in Seattle, and over, I think it's a third of the folks who died as related to homicides were dying in the streets because they're homeless, because of crimes that are homeless. So is Seattle dying? People are dying in Seattle because they don't have homes. People are dying in our streets because we don't have the funding to create shelters and the housing we needed. We tried, I think, and will continue to try to ensure that there's additional housing being built. But right now, let me be really clear again, 20% increase in our population since the beginning of 2010. 120,000 people moving to our city. We have not rezoned. We have not invested in housing. We have not created additional resources for affordable housing. And the result is people are quite literally falling into the street and getting pushed out of this city. So the one thing I would say is we have got to build additional housing so there's light at the end of the tunnel, and we have got to build shelters so there's places for people to move into. Otherwise, people will continue to die in our street from exposure, and also because they're vulnerable outside, which is what the data showed yesterday. Right now, I want folks to know that when you see people living outside in a tent or on the street in a sleeping bag, on quite literally the doorsteps of prosperity, some of our most prosperous industries in the nation are right here in Seattle. When you see folks sleeping outside, the actual number of shelter beds that we have open right now, according to the Human Services Department, is 3 enhanced shelter beds a night. There is no way that we are able to move in the 4,500 people who are sleeping outside without any shelter in this county into shelters when we only have 3 beds at enhanced shelters open per night. So we are seeing people die in the street because we do not have the resources we need to open up these additional shelters. That said, we're doing a kind of forensic analysis. That's not a good use of the word when we're talking about dying. We are doing an analysis of spending in this region. We are creating a regional board that will govern homelessness issues with the county, because if you see what Los Angeles did, their county and their city came together with companies like Hilton, with union members to come together to say we should be able to get additional resources. They tax themselves to basically earn about $1.3 billion a year, and they're building the housing, they're building the shelter, and guess what they've seen? City of Los Angeles saw a decrease in the number of people living outside last year, while the city of Seattle saw an increase. Per capita in Seattle right now, we have more people living outside than the city of Los Angeles. So we have a huge crisis that has an unmet dollar amount to go with it, but I think that we can follow the lead from some of our friends in Los Angeles County and City who've partnered with business and with labor, and they've actually brought in additional revenue. But we gotta build that housing, because even if you get inside to a shelter, you're still homeless, right? So we gotta build that housing. And that's a healthcare crisis too.
Well said. We have one question here I'm gonna end the poll everywhere questions with, because it was so highly rated, and I think this kind of goes to everyone, but it has many votes. In order to pay for social detriments, we likely first need to integrate data from across sectors, healthcare, housing, education, etc., align performance measurement targets, and then integrate payment across sectors. What steps are HHS, state, and city taking to advance this? Going to your comment that we're all very data-driven.
Yes, that's a big question for us. We have an effort called Reimagine HHS, which is reorganizing a whole bunch of us, and one is on integrating data. I give you one example where we got data sets from, I don't know the specific name of the data set, so I'll say the criminal justice system, but I'm going to misquote it, the datum, so I will not quote it, but I will. Your highest risk of dying of an overdose is within some period of time after being released from prison, right? Because your tolerance is gone, and then you go back and you get into your old social environment if we haven't had a good handoff, which that's another issue, maybe another conversation for another day. So we've linked those data sets to try and help understand. And one of our challenges is sometimes if we give grants from the federal government, you've got to reporting your performance on your grants to HHS, to HUD, to USDA, to whoever, and to various state and county and local agencies that are passing through, and they sometimes don't talk to each other. Sometimes that's in statute, so we need to break down those silos, and I think the federal government, HHS, and other departments have a big role to play in that, and we are doing that with some success in some examples. Oh, let me tell you, there's a specific example on the opioid thing. What I'm just talking about came out of what we called a codathon, which came out of the Chief Technology Office, and we got a whole bunch of people. It was about a year ago now. We gave prizes, and we got a whole bunch of people to come into the Humphrey building and actually stayed overnight. They were working so hard, some of them didn't go. They stayed overnight, and we had to get permission to let them sleep on the floor overnight, not because they were homeless, because they were working so hard. They were coders, right? And they were working at integrating these data sets. So we think our job is kind of make them available. And then the developer community, the coder community, we don't use the H word, obviously, in the U.S. government, not the coders, not the,
Somebody
exactly,
that rhymes with quackers.
Exactly, not the quackers. So, yeah, and we're like the artificial intelligence challenge I just mentioned would be a similar example. We give you guys the data, and you figure out the solutions.
I can be quick. I'm actually an economist by training, and it's incredibly frustrating, the lack of data that I have access to. I complain about it all the time. And John referenced the reality that part of it is that we're just very siloed. And I think that's something that is actually a surprise to many, is that even within the state family, we don't always share that information. Once you take into account the fact that it's healthcare, you also add that privacy element to it. So I mean, I think that's one of the first steps, is trying to figure out a way to break down those silos within even existing systems. And then even the simplicity within the state family of a need for data analysts.
Mm-hmm.
You know that in the private sector, this is a big challenge. And I had an individual recently, just this week, as someone who has a company, and saying that he himself is trying to be able to hire these data analysts for an affordable salary, and he hasn't been able to access it. And we're sitting there going, like, imagine us, like we pay like half that. And we're trying to get these good algorithms because how can you actually divert public money to appropriate policies when we don't have the policy we don't have the data to back it up. So it's a real challenge, but it is something that is very well aware on everyone's radar, and I think that's the first step. And so I'm gonna leave it at that.
All right.
I'm not sure that I'm totally answering the question correctly, because it's not about data integration per se, but one of the things that we recognize is that we, especially for our most vulnerable population, the folks we were just talking about, people sleeping unsheltered outside, we are asking people repeatedly to fill out the same questionnaire over and over again. And if you think about the folks who are sleeping outside, some of our most vulnerable populations, people who've been kicked out of their homes, let down by the systems in the past, had a lot of trauma potentially, they're reliving this every time they fill out a form, which deters them from going often to get some of the case management that they need. So as we're thinking about creating a partnership with the county, stop doing that, right? If somebody's coming in and they're asking for food assistance, don't ask them about the trauma that they experienced as a kid if they were sexually assaulted or something like that. Really just help them with what they're there for and have these systems that actually integrate and talk to each other. Another thing that we can take from healthcare, but an example of what they've done in Los Angeles. So treating people more holistically and thinking about that experience is one thing. The second thing I'll say is I'm looking upstream again, right? If one of the most important times in somebody's health, in what determines your health outcomes and your life expectancy, is your experience from 0 to, let's say, 2, but really 3, if your early learning years are determining your health outcomes, we have got to get folks into early learning, high quality early learning programs that are affordable for all. And that's why I see this commitment that I have to creating a early learning infant and toddler care in every city building as a healthcare initiative. DC's city council is taking it on. As you all know, the federal buildings in Washington, D.C. have childcare facilities on site. We can do these public policy interventions, I think, through a childcare lens that will actually have an impact on kiddos' health and their life expectancy and moms.
I respect that answer. And those questions that re-traumatize people are often driven by a grantor's requirement, so not necessarily us, but sometimes state, private grant, but whatever. So that's another problem we have to solve for sure.
Well, I'm sure we could talk for another hour, and I'd be delighted to do that. But in the interest of time, we have to wrap up and get to our final section, which is a rapid fire. And then we'll go to the promised live Q&A to end. So could each of you speak, and this is, again, rapid fire, maybe 60 to 90 seconds each, about what your highest priority needs that need solutions right now are. And we've been starting at this level and going down. So why don't we switch that script and start with you and come back up to the federal.
I'm gonna need your help with this rapid fire thing. Okay. So number one, I think we have a crisis that we could potentially fill in terms of access to that plastic medical insurance card in partnership with King County. We're really lucky to have some healthcare champions at the King County Council and executive. I would like us to have a San Francisco health plan model or the My Health LA model, which, if you're not familiar with those, are basically county-based insurance-like models. So we're in partnership right now with King County to try to figure out how we're going to cover potentially the 100,000 people who are without health insurance in King County, or if we wanted to be more specific, the 50,000 people in King County who are not eligible for any of our programs through the ACA. And the second thing I have, because I think I have 30 seconds, is we have a crisis that crosses all ethnicities and all incomes and gender. It is the opioid addiction crisis. And we have data-driven solutions from other countries that have shown these overdose prevention sites can help get people into treatment and stop deaths and overdose. So that is something I'm hoping that our federal partners can come along with at some point that I think that we can address here.
Great. Julia?
I'm going to speak to the life science global health sector specifically, and I would say workforce development programs and career-connected learning funding. And because part of my strategy is also finding ways to better support small businesses and startups and just the innovative ecosystem we have here. And the third is, I have to say, we talked about metrics and data, and I have to say that it's extremely difficult sometimes to tell your story. And that's why it's so incredibly important that as entrepreneurs, as healthcare providers, no matter what your role is within the system, to advocate and better educate your understanding of the system to policymakers, because that's the best way that policymakers can influence change in a way that benefits everyone.
Fantastic. And John, we'll close with your
So I'll put
most
in
urgent
something wasn't in my
need.
talking points, but the councilwoman mentioned it, is make sure you and everyone in your community is aware of the benefits of vaccination. The CDC
Yes.
declared measles was eradicated, I think, in the United States in 1980. Well, they proved us wrong. So the Surgeon General actually came to Vancouver, Washington, and Portland and was talking about that. So let's get that message out there and not let an outbreak like we've experienced come again. Opioid epidemic again. We need to, I'm very encouraged by some things I've seen in some counties around the region of kind of an all hands on deck approach, sharing data, the sheriff, the public health, the primary care, the substance abuse, the housing agency. They're sharing data, sometimes in a formal way, sometimes just in a conversational way, and realizing that that they need all hands on deck at the local and county level. And let us know, because we have a lot of grant making there. We don't know unless the local folks tell us what we're doing right and wrong on the opioid epidemic. And finally, I'm gonna say price transparency on a lot of things: prescription drug prices, hospital prices. Certainly for those of us in the employer-based system, or those who are uninsured, or even Medicare in some cases, the providers just have to get transparent about what you owe them. The drug makers are forced by the FDA to describe side effects, clinical side effects of their drugs that they sell. They promote heavily on TV and in magazines, but they don't have to tell you about the side effect on your wallet. Well, we're changing that, and thank you.
I could talk about that last one for the whole hour. So, well, as promised, we're going to go to a quick 5-minute live Q&A and then wrap up. So maybe just a couple questions. Nick's got a mic back here, so go ahead and raise your hand. If I didn't get to one in the app and it's burning, you can read it.
Thank you all for being here. It's been great. Quick question on things like high deductible health plan, and I know sort of early on you all had sort of touched on, or maybe Cassie you had touched on, paying for care. And so I know part of it is bringing down the cost, some of it's paying for things. HSAs, being able to tax-free pay for some of your medical care. Is there something from a policy standpoint that's being done in order to help people pay for their care? Thank you.
You mean further reforms to HSAs, or?
Thanks. Anything that's come down the line that either one is inside of HSAs, that's fine, or two, things that you've seen that the average person can use, a plan that our government has brought in new that would help the average person pay for their care, that you've seen that maybe is there's not a lot of awareness, and so this group, we could go out and spread that gospel.
Well, I think when I said price transparency, that's what I mean. If you have an HSA, you need price transparency, obviously. HSA's been around for a long time. They're becoming more popular, but we don't have, our reforms on health insurance, I mean, health reimbursement accounts, the association health plans, and the short-term limited duration plans, which I don't really see much point in talking about, because they're either under litigation or the Washington Insurance Commissioner won't. God, this is being recorded. If the secretary hears I said there's no point talking about it, he'll fire me. But anyway, the state insurance commissioners are kind of in charge of whether people have access to those things, and certainly the association health plans are being litigated now. So obviously I don't talk about stuff that is in the hands of the lawyers. Thank you. I'm not sure I was useful, but thank you.
A recent conversation that I had with DoorDash executives reminded me of my days when I was with the Health Disparities Advisory Council with Christine Gregoire's administration. And it made me think about sort of the food deserts and the impact that that has to the vulnerable populations. And now we have the infrastructure to allow for food to be delivered to a lot of folks who live in those areas. Are there any innovations that you're thinking about for the SNAP food program specifically in utilizing some of those infrastructures that are currently in place to deliver upon healthier food options that may redress diabetes in the vein of the Virta and Omada and Livongos of the world?
Mentioning that. So The answer is yes, and I can't answer it very well because that SNAP program is in the U.S. Department of Agriculture, not in Health and Human Services. Now, the president would like to change that. He proposed a year ago that SNAP and WIC come into HHS so we could do this in a more integrated way. And Congress hasn't acted on that. I do believe USDA has, I'll get it wrong, but they have tilted it towards more healthy choices, and I don't know the details, but there has been some rulemaking on that. Yeah. Yes. Yes, and the Medicare Advantage plans can do that now. Transport, housing, and I believe food are now, the Medicare Advantage plans can put them in the mix. There are statutory, on the Medicaid side, there are statutory limits to doing that. So that's, I don't know if we've called for a statutory change on that, but we recognize that there are statutory limits on Medicaid plans doing that. So there's a discrepancy that we're from the government, we're here to help, right? So
I just want to mention that there's something called the State Health Improvement Plan that was just put together by a number of state agencies and a whole range of individuals who are at the table trying to address these kind of issues and public health being included. I also want to touch on something that the councilwoman touched on. There's an organization called Global to Local that works in South King County, and this is not specific to, well, they actually have a program that has to do with healthy food, but what they're doing is trying to also bring services to individuals who might not have time to take off from their jobs to be able to go to the dentist or the doctor or what have you. So trying to find a way to address underserved, and they're even looking now at rural communities too, to be able to help improve the health outcomes. And so it's about the public health, those approach.
I'll just add as well. Did we get a chance to serve together on this health disparities task force? Okay, because I had a chance to do that for 2 years too. So I really appreciate you bringing up the issue around food deserts. Also, I just heard the term childcare deserts recently to try to mirror a long time effort around increasing access to healthy foods. There's two things I would say. One is, a number of the individuals who receive the food through these food apps, I think we all know, and I receive it all the time, we all know that it's quite expensive as well. To get food delivered, I don't necessarily know that helps us with the cost side and the access to affordable healthy food. So that might be something that we should think about if we go down this path, about how do we make fruits and vegetables more affordable, because they're still so much more expensive than they are for the unhealthy foods. The second thing I would say is that there is a nexus here with sort of the worker dynamic that I mentioned before, because a lot of the folks who are driving using these app-based technologies, a lot of them are living in food deserts, and we're hearing a lot about these folks being classified as independent contractors versus employees, and again, yet subject to their app being turned off if they get a bad rating, not being able to sort of adjust the app so that there's more clarification to the consumer about how much the worker, the independent contractor, is getting in terms of a tip. And so there's a lot of this economic instability that's built into that system that I think also kind of gets back at how do we create more economic security so that income inequality isn't driving health outcomes. So that would be one thing that I would love to think about as we think about this too. And then the last thing is, as I've been talking to folks who've been working specifically in Seattle, mostly in the Rainier Beach area, what's come up most as their desire is access to land and access to affordable living, affordable building space, because Seattle is so dang expensive. They are having a hard time purchasing land to do things like pea patches and allow for folks to grow the food that might be more ethnically specific to the community in the area. And they're like, help us get access to this land so that we can actually grow some food and have these pea patches to serve our local community. And when these giant new buildings are created, please, for the love of God, create some sort of incentive so that there would be a grocery store inside. So those are two things that I think we're working on that I feel like, okay, I have a little bit of leverage on those two pieces, so that we're creating an incentive through the Mandatory Housing Affordability Act that just passed to say, we'll give you additional floor area ratio or maybe additional height if you're including things like a childcare or a grocery store on the first or second floor. And if you think about the amount of land that the city does own through places like Seattle City Light, we have that whole patchwork of greenery that goes through the south end that has, of course, it has the electricity lines over it, but folks are like, can we please just grow some food on this land on the ground? And I'm like, that's brilliant. So we're working on stuff like that, but those are two of the issues that I've heard from the community that they really want in terms of addressing the food desert in Rainier Beach. So love to work with you on that.
Well, I think that's a fantastic question to close on, because it got to touch areas everyone has been working in, and we're out of time. So thank you all very much for coming, and a special thanks to our panelists who have been fantastic and delightful, very informative.
Thank you to our panel. This was an excellent conversation, and clearly we could talk all night. And we will continue the conversation. I want to draw your attention to our chalkboard over there. I want to highlight on the 17th, we will host Dr. Dawn Rucker. Dr. Rucker is the National Coordinator of Health IT, so we will dive much deeper into a lot of the topics that we covered here today. So please join us for that. And on May 2nd, we will have our provider panel continuing our 5-point series. So please join us for that and continue to come back to the Cambia Grove, and we'll continue this conversation. Thank you all for coming, and thank you for your excellent questions. We will use those to help spur this conversation along as well. So thank you for your contributions there. Thank you, everyone.